Zoom.
Recording in progress.
We're very excited to have you all join us today for this special presentation. We have a guest speaker who's come all the way from the UK to visit us here at Stanford, and she's going to share a lot about her community engaged research. But before we get started with that, I'm going to go ahead and walk through some just housekeeping slides. No. Oh, awesome. So really quickly, want to have a big shout out to the MCHRI Education Committee that really helps to plan all of these sessions and puts a lot of great work into the educational programming. You can see them, they're all listed here on the slide. And then also want to just remind you that in October, we're going to be having the MCHRI Annual Symposium. And you can see that we have a number of great topics planned, including climate change in maternal and child health, PedsNet, which is a large infrastructure database here at Stanford that actually pools medical record data from a lot of various children's hospitals to increase research on child health topics. That's also going to be a highlight session too. There's also going to be usual groundbreaking research from rising scientists and a session that's dedicated to omics in maternal and child health as well. All right, so we're going to get started now with our special presentation. So I'm happy to introduce Dr. Semira Manaseki-Holland. She's visiting us from the UK. And we're very thrilled to have her talk about community engagement for maternal and child health interventions, designed delivery in low-income populations. She's specifically going to be talking about a few examples from Gambia and also Mali. And just to give you a little background on who she is, she trained as a public health physician. She's a professor there at the University of Birmingham in the UK, and she has joint qualifications in pediatrics. She has research leadership that focuses on health systems and maternal and child health, mainly in low-income and middle-income community countries over a 25-year period. She's worked in the English NHS for 9 years, after which she intensified her global health research and health delivery system, including living and working on Mongolia and Afghanistan. She's also worked extensively for the WHO headquarters, UN agencies, ministries of health, and also NGOs on a variety of settings and health programs. So we're really thrilled to welcome her today and look forward to any questions you have as well. If you're joining by Zoom, please put them in the chat, and then we'll moderate a discussion at the end of her presentation. Thanks, everybody. Is this working? Okay. Oh,
do I start? Thank you very much, Anita, for that very kind introduction. And it's a real privilege to be here. Thank you for coming and giving me your time. So am I okay to move around? So I would like to share with you some personal experiences from my research, recent research in the West Africa, the Gambia, which is an Anglophone country, as you probably know, and Mali, which is a Francophone country. Some ways quite different from each other, even though climatically and culturally, in terms of tribal background, they're very similar, like linguistically and so on. So I was very interested to hear about your work in terms of working with communities and involving communities in research and intervention development. And so that's the part I'm going to focus on. And I do apologize that I won't have time to explain all the different components of this project, which are, they're both linked actually. Gambia and Mali projects are quite linked. So if you have specific questions on those projects separate to community participation, I'm sure there'll be lots of things not quite clear. Please do ask later. So I'm going to try to cover some basics of what we call in England community engagement and involvement in research. And when it comes to low-income countries, that's what we call it. In England, we call it PPI, public patient involvement. I don't know why we have different names for it, but I'll set the scene with that just so that we all speak in the same language, and then background to the projects, specifically these two projects, and then in what community engagement involvement means in these projects, and some results of a cluster randomized trial using this intervention that's developed. So as you probably know better than me, I'm not actually an expert in community involvement engagement, but there are different levels of this. Starting from, this is just from a reference in Australia that I got, but there's many different forms and shapes of this kind of slide. So inform, you just tell people what you're doing. Consult, you tell them and maybe ask them, well, what do you think? And perhaps superficially. Involve, in this definition, is more including people right from the beginning in the development of your intervention and research, and asking them, you know, advice, if you like, and their input. Whereas collaboration with communities would be more actually having them help you develop your intervention and study design and research. While empowering, I think it's probably quite difficult for at least the research side of the a study, but certainly for intervention, I guess you could have situations where a whole community just comes up with the intervention. I don't know of any examples, but there may be some out there. I just say I'm not an expert in this. Of course, I'm not sure what the background of the audience is, but some of you may be just clinicians or clinicians and researchers. And essentially, I personally, my experience, that there is a difference in community involvement in terms of research and service delivery. So if you're talking about health systems and you want to deliver a health system intervention, you're not necessarily bothered about how you're going to evaluate it. I think personally think that's probably quite a lot easier to involve communities. If it's very specialized in a particular aspect of medicine, say, you know, pediatrics, intensive care, whatever it is, obviously communities don't have the depth of the medical knowledge, but in terms of how that expertise that you have can reach the population that you want to reach, then I think communities do have a lot to offer, because it's one thing having a very good service, but or even whether it's accessible or whether it's utilized is a totally different story. That I'm afraid we don't have time to address today, although we will cover service delivery in terms of a community intervention, which is what I'm going to describe. It's a kind of service, isn't it? But it's sort of, in our case, it's going to be delivered by the communities. In terms of research component or research angle of community involvement, I would say, again, there are components that are easier for the communities to get involved with, and some people are very good at it, and other parts which are harder. And I personally think it depends a lot on your length of your project. If you have a very short timeline, 2 or 3 years, then it's actually very difficult to involve communities in a meaningful way. That's my experience. If one has time, developing a study question and problem definition, often I feel it needs to start from the researcher, but communities can really help us define what those questions should really be that's meaningful to that community and will be later on applicable. Then you have the study and evaluation design. That often is very difficult for communities, although if you have informed communities, informed patients who can be, welcome everyone, if they can be involved and informed before they help to develop the study design, I think even that probably is possible. Intervention design definitely is possible, and intervention delivery is definitely possible. And I guess also there, before we get into too much depth in this, you know, community, definition of community is not that black and white, I would say. Right? So a community could be your medical colleagues. That's your community that you're addressing if you want to change behavior of medical practice. If it's behavior changing communities, nutrition change or whatever, well, then that's the community, the public out there. But I don't think it's so black and white. So you could have people who are very well informed about study designs, who are your target population and can help you develop your study evaluation and so on. So then you've got evaluation tools and design. Again, often that comes from the researcher initially, and it can be very well adapted by the population themselves. I do have a colleague in Aberdeen, I think it was, that actually designed the whole study from scratch with the local population somewhere in South Africa. Validation and contextualization of the results should definitely be done. Usually it's done in qualitative research, with the local population. And that's extremely valuable, because you may think that actually what you've got is highly relevant and valuable, but actually it isn't for that population. And dissemination and replication scaling of any intervention for sure is something communities can get involved with. So the challenge here is, how do you do these things? So the projects I like to talk about are both very similar in their context and their sort of, description. So I'll do them together if you don't mind, and I hope I'm not going to confuse you too much. So basically, the projects are quite simple in their concept. You would be very familiar with a lot of research on nutrition, how to feed children nutritiously, and a lot of projects on water sanitation, hygiene, WASH. How to have clean environment and hygienic practices at household level in any country, but especially in low middle income countries. However, there is not much research, at least not until recently. We've done a large volume of work on this, and there's one or two other groups who've done studies, particularly looking at interventions where you're combining hygiene, food safety, and nutrition at household level. So there is, again, a lot more. There's a whole field of study on how to, make sure the restaurants and food suppliers are hygienic and so on. But household level is a different story. And of course, somewhere like Africa, people don't go to restaurants and buy ready-made meals. So what happens at home is really quite important in terms of feeding at least children. There is street food. That's a different story. But this concept of household food hygiene is really important. If you have the most nutritious food in the world, but it transmits pathogens to you, you're not going to be a happy bunny at the end of it. It all comes out the other end. So, and in terms of children, diarrhea is second, third biggest killer in low-middle income countries. The other concept that's quite important in these two projects is that knowledge and behavior change are not the same. So you could have like here, we all know we should do exercise, we all know we should eat healthy food, and we have the means, but actually a lot of people choose not to go, including myself, not to do much exercise, not perhaps to have healthy food and so on. So knowledge and access is not equivalent to behavior change. So it sounds very basic, but actually achieving behavior change is often the big challenge. So to be able to support women to change their behavior, so this empowerment of women actually also, in our experience, involves a lot more the community around that woman. So traditionally, if you do maternal-child health in low-middle income countries, and perhaps in the States, I'm sorry if I don't have enough background of research in the States, often projects address the woman, right? So you have a community health worker, whether they're paid or unpaid, well, they go and talk to the woman, go and have certain number of sessions with the woman. You have your flip chart here, and 3 times visit a month, and you communicate this time and that next time and that the time after. And majority of these women are young girls who don't actually choose very much. They may not even choose the menu for themselves, or even the clothes they wear in some of these countries, unfortunately. So actually addressing the woman alone to make those choices is not terribly empowering and isn't going to bring about much behavior change. So I'll describe in a minute some findings that we have that demonstrates that actually knowledge is not enough, and these women need more social support and social norm change for them to be able to change their practices. So the two projects were essentially both about weaning food hygiene and safety at household for the mother in terms of preparing complementary food. But in Mali, we added to it better nutrition as a whole, as well as play hygiene. So not playing on the ground and eating the soil or animal dung or whatever that is in the yard. So these two projects were called Ma Champion in the Gambian setting, which was only food hygiene. And then MCHRI, that's read as Che in the Bambara language in Mali, is the more comprehensive, the bigger scale project in Mali. To get a better background on these, if you're interested, the Gambia study, there is a publication in PLOS Medicine of the trial, and the Mali study, Assam and et al., is the protocol for that study. It's still ongoing, so we haven't got results to show you for evaluation. So a little bit on each project. My champion study is in the poorest part of Gambia. Gambia is a very small country in West Africa, and the population we had was around 200,000, very high rate.
That means nothing.
Country.
What if I open with an anecdote
Okay.
that talks about bathroom stalls?
It's okay. So this is the Ma champion. Ma means mother, champion. So these were two titles given to mothers who achieved this behavior change and they became ideal mother in the community. And I'll explain that as well in a minute. See that? No, that's okay. You don't see that. The MCHRI, oh, I haven't changed the top. I do apologize. I should say MCHRI study. That's the one in Mali, and it's a much larger study. The one in Gambia was only 30 clusters, 30 villages, is rural. The MCHRI study in Mali is across urban and rural Mali, 120 communities, very large, very challenging. Mali is a conflict zone. It's a bit like Afghanistan of Africa. Most of northern and central Mali is in civil war. We work mainly in Bamako, which is the capital here, and the communities around, or the villages around there. And it's a large randomized controlled trial where communities are randomized to either intervention or not. And in Gambia, it was the same. There were 30 clusters randomized to intervention or not. In Mali, the population is quite large, and it's also tropical, but mainly also some deserty areas. Thank you. Are you okay? Do you want me to stop? So a little bit more background. They're both very similar. As I said, they're both looking at food safety and hygiene, except that in Mali, the actual better, more balanced diet for the weaning child was addressed. Now, again, if you're familiar with child nutrition in low middle income countries, usually it's breastfeeding, that's the main emphasis. There isn't much emphasis on complementary feeding in studies. So this is in some ways unusual. And also this hygienic play has become quite a topical thing in low middle income countries because it's become, you know, a lot of observation studies have shown that children play in the dirt. Toddlers, obviously, if you've had a toddler, you'll know they just pick anything up, and often there is pets in the yard, there's dirt in the yard, and there's actually belief systems that this is good for the child. It will give it immunity. So they will, and quite commonly they would swallow animal dung and so on. So we're trying to address these three behaviors: behavior on food hygiene, nutrition, and play. Quite difficult because they're all culturally ingrained. The way you feed your children is often quite emotive. Mothers care a lot. They get quite emotional about what they can and can't feed their children, whether the kids are eating it or not, and so on. This we don't need to go to. This is multidisciplinary studies, both of them across various disciplines. Right. So we would now talk a little bit about the background, the research that, if you like, has built up to these two studies. So we've got existing research starting off in Mali, actually, about 2008, and got published later on from the guy, from my colleague who's now the co-PI in Mali, Professor Touré. And then he just demonstrated simply that mothers in the household level are exposing their children through the way they behave and the way they make the food to pathogens. And this study was followed by an intervention, simple intervention at the mother level, not community level, repeated in Bangladesh, In Nepal, another colleague made this into a community intervention, but quite high input, so that makes it very difficult to replicate. If you want to replicate a public health intervention, you can't have lots of visits and lots of individual interactions, it just becomes very expensive. Then we had another study, which was not about food, but about just simple hygiene in India called Superama project. I don't know if anyone is familiar with that, done by London School of Hygiene. So many of these colleagues were based at London School of Hygiene. And we used the low intensity input into communities that these guys used. So we combined basically these 4 types of studies. Part of the component of all of them is this concept of assessing mother's cooking in terms of a hazard analysis. So I don't know if any of you are into business, you know that, for example, if you make a car or you make any equipment in a factory, there are critical points where if things go wrong, that device will not work or that manufacturing process will not work. And this is called the hazard analysis critical control point. And they do this for food safety as well in factories and in restaurants and places like that. So for the first time in Touré's project, he used this methodology for assessing the household behavior of mothers. So we use this, observe the mothers cook, and work out where are the critical points where things could change that would make a big difference to the food safety. The other notion, theory or concept that is applied here is this concept that, as I said earlier, knowledge is not enough, neither is access to equipment and things, but that people are motivated to do things through various different means. So the theory behind here is Evo-Eco, a theory of behavior change. So for example, you know, a mother really is motivated to help the child grow and feel that she's a good mother. It's not just about a child having illness, having diarrhea or dying. It's about being a good mother. You know, that is something that motivates a lot of mothers or parents, I should say, or being accepted in the community, doing what everybody else does, you know, because you don't want to be different. Most people don't want to be different. That's affiliation. Or the sort of the concept of disgust. You know, that's disgusting. I'm not going to do that, you know, and different people have different notion of disgust. So these are all psychological motivators for behavior change. And when you do the HACCP analysis here, you come to these points and then you're supposed to prioritize them and come up with some corrective measures or behaviors that would correct that problem. So to deliver these corrective measures and the motivational drivers, you need, if you like, methods of delivery that would achieve certain methods of behavior change. So this is really important for me because you could have, you know, you could have done the best analysis in the world and the best motivators, you worked it all out, but actually how are you going to deliver that? And this is where the communities come in. How are you going to deliver that so that the behavior change actually does occur? So in our case, we didn't actually initially go for social norm in Gambia, but we found that that is what happened using this kind of methodology that follows. So the social norm change came about really through involving the whole community, not just the mothers, grandmothers, fathers, community leaders. So in low-income countries and maybe even ethnic groups within a country, often there is a so-called community leader. That doesn't have to be a religious leader. It could be formal or informal. You know, people who meet in the village, they are informally the leaders, but they're not the administrative leaders, if you like. But they are respected, they are trusted older members sometimes, or what have you. So this is very important to involve these people. We went for the campaign method, which was the Superama method. So campaign, you know, method is sort of bang, bang, bang. It's hard for a day or two. And then you're relying on this process to continue through your community leaders and your contacts. So in our case, it was also involving peer education, peer support. So we had these older mothers who were also part of the community, but also the model mother, which I'll come to in a minute. So if these mothers got engaged and adopted the behaviors, then went and told other 2 people, they become the model mother, right? The ideal mother. And that in itself propagates your program. So this sustainability of any behavior change or health promotion program is a huge challenge globally. How do you do that so that when you finish your project, you run out of money, people don't start doing other things, right? So this is one of the ways we found was effective, was getting those mothers who get engaged and other people in the community to become peer educators, peer supporters. That involves doing home visits. We adopted the notion of cultural performing arts. And for Africa, this is just so natural. This is the thing you do in Africa. And actually, people don't do it in research and in medical world, unfortunately. But naturally in Africa, and actually many cultures, even in the West, you know, if somebody's performing something in the street, you stand and watch it, don't you? So this kind of creativity, especially if it's culturally ingrained, is very powerful, especially for addressing difficult topics. And hygiene is a difficult topic. You don't want to be talking about people being dirty or causing disease or problem for their family. So you can do that through comedy and through songs and through dances and joyfully, actually, rather than miserably through talking about death. So we use this idea of cultural performing arts, and I'll explain that in a minute. We also had social marketing concepts such as environmental cues, staging the targeting, staged targeting of the behavior change, and non-monetary rewards. So this is just, our study began with a formative, both studies, all these studies, most studies start with formative research, where you're trying to work out basically what are the practices you want to deal with in that setting. So our formative research included observations in 4 or 5 communities, actually spending a whole day with the mother, semi-structured interviews, focus groups with all kinds of community members to try to really understand and unpack the issues there. So as I said earlier, no rocket science, no surprise that actually knowledge is not sufficient. And this is a good example of it here. So all the mothers this is a Gambia study. Just an example, we have the same from Mali, very similar thing. All the mothers, so you see all the mothers, no mother had no knowledge. All of them knew how to make hygienic food, right? All of them knew in this case that they should wash their hands with soap before they cook and before they feed their baby. We observed 30 mothers, okay, 27 didn't even wash their hands with anything before they started cooking or fed their babies. 2 of them washed it with soap and washed one without soap. So that's really quite interesting, isn't it? I mean, it tells, it doesn't need much explanation. The formative research, this is the Gambia one, identified 6 priority behaviors that we wanted to promote. So that became the foundation of what we wanted to do. And the motivators that we identified were very classic sort of WASH-related ones for child health. So nurture is mother wanting to rear a good child. And disgust, I mentioned, a status is, you know, if they feel that their status is improved, people think they're a nice, clean person and so on. And affiliation is that social norm, doing what everybody else does. Purity is godliness. So a little bit now about the interventions in the 2 countries, and then I'll go into the community participation and development part of the work. So just so that you understand what it was about. In Gambia, both projects were very similar. So I'll go back and forth. It's quicker. Otherwise, we'll be here till tomorrow. So both projects, after the formative research, we essentially got a team of local artists, so not researchers, and local health workers. So not high-level doctors or anything like this. These are public health officers in villages and communities, known to those communities, part of those communities. Same with the performing artists. They weren't like coming from the capital or somewhere very special. They were just local people. And in Africa, this is very common. I mean, we have it here as well, local singers and so on. And as I said, it was low intensity, low cost. So that meant each community, say each village or part of the city, got 4 days of campaign visits by this group that were 2 performing artists, a male and a female. She was even totally illiterate, this lady, and 3 public health officers. They would go day 1, day 2, they say hello to the head of the community. So for example, here in Mali, similar thing, saying hi, the head of the community, and then explaining what you're doing, asking them to be a role model and like a champion, if you like, product champion. You photo them like here doing the thing that you want them to do. Hopefully they agree with it as well. They're not just doing it for you. And then you also train some volunteers that the community has chosen, not you, and they're not medics or health workers or anything. They're just normal mothers who've had their babies already grown up. And then we went door to door, invited people to community events like these. Okay, you can see all these people have come from the village, from the community. Here is the same. And in these community events, they would be singing, dancing, performing your behavior messages, behavior change messages, but in the form of performing arts. And really very joyfully, not talking about disease, hardly talking about disease and diarrhea, unless it came up by the local people. So it's more about, you know, you're a good mother, it shows how much you care, it's the future of your village, it's the future of your family, not about, you know, your child will die tomorrow if you don't do it and they get diarrhea and all this. And in Africa, you know, people join in. So as I say, unfortunately, I don't have enough time to show you videos, but, you know, women would get up, they dance, they join in with the singing, they repeat the song, the children learn the songs. You can't see this very well, but the children in this front row, the men are invited, community leaders are invited. You see, this is here is the drama, right? So drama is very low key. This is not like a stage. You go and somebody stands on the stage and they've got props and they change their clothes. Nothing like that. Everything is just, what's the right word? I'm not a performing artist myself, but without much props, right? It's very natural, but funny. So the whole drama is very much a comedy act, really, between a mother who does all the right things, this Marchawara or Mar champion, the ideal mother, and with another person called something else who doesn't do these behaviors. And the fun of it is to watch this person. And in both countries, we've now done our qualitative post-intervention evaluation, but not the quantitative. So I can't tell you health outcomes in Mali. But in both Mali and Gambia, we found that people remembered this person that wasn't doing the right thing and identified with everything. And they were happy to do that. They were happy to laugh with this person and happy to call each other, oh, you're a Bawasa. Look, you don't do that. That's been a Bawasa, you know. Bawasa does that. And children call their Bawasa's other person, for example, the name of this other person. And children call their parents out for this. And, you know, you gave me food without washing your hands. So very interesting how it penetrates and stays in the community. This is in here, the picture of a mother visiting another mother. So she is not one of these trained, these guys get 2 days of training, that's all. So then this model mother, ideal mother concept is very powerful, certainly in our setting, because most of our mothers don't have anything. They don't have jobs, they don't have literacy, they're illiterate. There's 20% of all women in Mali are literate. And so majority of these village women have no education and really no status. So if you can achieve an ideal mother status and you get a badge and publicly you're awarded and you're celebrated, it's a huge motivator, really, was what we found. So in Gambia, which was done a few years ago, we went back after 32 months, which is nearly 3 years. You know, it's quite a long time. Me, to be honest, thought that nobody would remember anything and it would have just been wiped out. Because we had this 4-day visit and the reminder visit after 5 months, and we had no money to do anything after that. And by the way, the Gambia money was a PhD student and 20,000 pounds. I think the whole thing cost 100,000. 30 cluster followed up 3 times with qualitative study. So you can't do things cheaply. You don't need millions of pounds to do things. But anyway, so the thing is, we went back after this 32 months and they were passing on these behaviors to new mothers who weren't around during the time of the intervention. And even we could assess and we could pick up the effect of this in our quantitative survey, which is quite an unusual thing because after 3 years, you know, usually you have a huge dilution of effect. So here, this model mother has stages. So I mentioned before staging of behavior change. That applies to anything, medical students, mothers here, anything. You cannot achieve, you know, the top thing from nothing. So to enable people to to behavior change in stages, as I say, it could be professional behavior change, it is very helpful because you can go from one stage to another. Maybe you don't go beyond that. At least you've moved forward and you've had that recognition. So we have the first stage is pledged mothers. They pledge to do this. They learn all the behaviors. They don't do anymore. They get celebrated. They get pictures. You see, pictures are taken. These pictures are put up on boards in the village. Everybody sees my mother has pledged. My wife has pledged. I'm so proud of her. And then the next time you go and visit them, day 2, day 3, and they hopefully moved on. They've started practicing. You can see they're doing things. And the other women come and observe them that they're doing things. They then move on if they manage to recruit another 2 or 3 women. So then that is now propagating, right? And then they become MCHRI, they get a badge, they get celebrated. And we had feedback, I'll see if we have time later, where basically the messages from Gambia after 32 months was, it was joyous, it was brought us together. We felt that we were as a community more united. Women with their medals, they go to the clinic together and fetch water together. I mean, this is not something we planned, right? But I reckon it happened because of the community, because of the way the intervention was developed, not because of what we did or what ideas we had. So this is now coming back to the theme of community involvement and community participation in intervention development and delivery. So if I can now recap more in terms of these concepts, then hopefully it'll make more sense. So I know I've only patchily described the intervention, but essentially at the time of intervention development, clearly you can't involve every member of the community when you're developing or delivering, right? Or involving the community. I mean, this is for me, I'm not a social scientist, but I don't actually know what it means, community involvement, because we have 2 million people, for example. I can't involve 2 million people in developing my intervention. It's just impossible, right? But the people that I've got helping me develop the intervention and deliver it are from the community. They're not researchers, they're not medics, they're not professional public health people. These are singing dancers and drummers, and they're public health officers and so on. So that these getting people who are from the community and not professionals, researchers, is part of the trick. Now, as I say, it could be your community health workers, it could be your performing artists, it could be community leaders, it could be the children, it could be the mothers. In the case of a clinical scenario, it could be your colleagues, who are not researchers. So that is very important because they were recognized when they visited the communities. So these people not just helped develop, shape the intervention itself. So you're telling them, okay, we did the formative research together. In this formative research, we found that, mothers don't wash their hands, but they know they should wash their hands. So, how are you going to communicate that? How are we going to encourage mothers? So then they would come up with the details of the intervention, of the routine of what's going to happen when you go to the community. They need a framework because you only have a certain amount of money. So you can't say, well, you can do whatever you like, just sit here and give me an idea. I mean, I couldn't do that for you. I need some framework. I've got this much money, this many days. This is the kind of thing possibly, but you could go beyond that or outside of that. So when you provide people with that kind of framework, then, and also a kind of level of training, I suppose, in your area that you want to bring about an intervention, then my experience is that people are far more able than researchers to be very creative and come up with the ways that it works for that community. And often things that we haven't conceptualized, we didn't realize are barriers or issues. So how do we do that? We involve them in the formative research. So again, formative research was not done by researchers, trained researchers. It was done by, even though it was focus groups and semi-structured interviews, it was done by training local people. These community health workers, so they weren't illiterate mothers, but they were from the community. Then we designed the intervention by having the groups come together, the dancers, the singers, and the public health officers, and one researcher. And you sort of nurture them. I don't know if that's the right word, if you understand what I mean. So accompany is another word. You accompany them. So you provide the framework, the evidence that perhaps you found from the literature or from your formative research, say this is what we found. and we want to produce, want to bake a cake together, basically. And, you're sort of accompanying them rather than telling them what to do. So where they're stuck or where they're supposing something that costs too much or is just not practical, then you can have a consultation. Everyone knows that everybody's life's got limitations. So nobody expects you to do everything what they, say. So then in terms of delivery, so again, we don't have professional researchers or, people delivering this that are outside of the framework of these communities. So those people who develop the intervention, deliver it and train their colleagues to deliver it. So that itself, again, brings about more trust and more, certainly in low and low-income countries, they're used to these NGOs and United Nations agencies coming in, here's yet another project, here's some, some leaflets and some free food or some free supplement or whatever it is, they come and get things from outside, the project ends, it all ends. So they expect to get things, right? So in this project we had, because we were poor, to be honest, we couldn't anyway give anybody anything. My PhD student barely had enough money for himself. So they got nothing, not even soap. And I remember people, I thought myself, without soap, they are so poor, it's the poorest people. But actually, everyone in the world nowadays has access to soap to wash their clothes and wash themselves once in a while. It's a matter of a priority. And that's what we found, the poorest part of Gambia and Mali, they have enough water and soap to do these changes. It's minimal changes if they prioritize it as families and as mothers, without giving them things. Because when you give them things and you go, they cannot sustain it. No one will give that extra soap, even if it's just very low cost, right? So the less you give, I believe, is the best. And let those members of that community, again, this community could be your colleagues, because you want to change medical care, but the less you give enables sustainability of that program. And the more they're involved in developing what it is to do and say, the more likely it is that when you're gone, they're actually still going to continue passing that on. And make that formal. How can we formalize this in this community? And I learned from, I'm not African. I didn't really know much about Africa till I went to Gambia. And when I do my projects, both in Gambia and Mali, I've gone for months. Last year I was 7 months in Mali and more or less living there more than I was living at home. So I think it's really, I've picked up, I've become a richer person for that exposure. And I've learned that, actually communities, these people have survived for centuries, and they've had very fulfilling lives. And who are we to say that we have a better answer on how to pass on important messages about life? So they have their own ways of doing it. And so, and we don't have time to talk about all of that, but women's group, female volunteers, community leaders, and so on and so forth. And the empowerment, do you remember we had stages of community involvement? Final is empowerment. It's a very hard one. I don't know how you do it in research, but I think after 32 months, when we found that they were passing it on, if that's not empowerment, and if social, what is it really? I don't know. So I don't know. I don't think. We didn't really do as much as apparently one could and should do. And say I'm learning in this field as I go along. We could have, for example, focal point colleagues in communities as we go along, so that every month, every few weeks, you touch base with them. How is it going? Is it what's the community feeling, or can we do more or less of this or that? Community informants is a sort of similar kind of concept, and consultative panels where you get your community engaged and involved throughout. So it becomes a dynamic process. We couldn't afford that. We didn't have that advice at the time. Factors that influence community, but transparency is so important. People are often more intelligent and able than we are, even though they may have no literacy at all. And they can read your heart and your mind when you're there because you want your promotion, or because you want your grant to work or write a paper. I feel that we should love people that we work with, and that research should be about mutual benefit and loving people. And that transparency, if it comes from the heart, people do anything to make it work themselves. And that orientation and information, which is part of the transparency, is very important, of course. Of course, they don't know about this science and that science, but you can tell them, you know, if a science can't be translated into normal language, it's not, you know, you can even talk to people about astrophysics in simple language. So I think we can orient people of all backgrounds, of course, if they're willing to hear, in a way that they can use science and evidence. And then this concept of accompaniment, which is what I mentioned earlier, we do need to accompany them and explain about limited resources. Of course, everybody knows that resources are limited. So the last point here is quite an interesting one for behavior change. So that's one thing for developing interventions up here, these factors. It's another thing evaluating it, right? So if you come to me and say, I want to see how hygienically you cook, and 3 months ago you were telling me about washing my hands before I cook, well, obviously I'm going to wash my hands when you're watching me. So where does that transparency and to community involvement come in, right? So this masking is really important. I don't have time to cover it properly. Some of you are probably more experts than me, but obviously one way is that you evaluate something bigger and your outcomes is within that. So I can get consent for observing your activities throughout the day. And within that, of course, I'll watch you cooking, right? But I don't tell you that I want to watch you cooking. I'm not lying, but also I'm not creating a situation where the biased observations can take place. So I'm now, I think I've talked far too much. I'm going to very quickly give you the Gambia results just to tell you that it works, honestly, to my surprise, because I'm a hardcore pediatrician sort of trialist. And when I came to this space, I didn't think this would work, I'll be honest. So that's why I think I want to share it. So this is the Gambia study, the 30-cluster randomized trial. It had a 6-month evaluation and it had a 32-month evaluation. The intervention happened, as I said, over 4 days in a month, and then a reminder visit. And very quickly, I don't have time, unfortunately, to go through these, but this is the characteristics of the villages, characteristics of the mothers. You see, majority were illiterate. And so those of you familiar with randomized trials, you know that the data would get presented on control and intervention kind of columns. And so this is what we've got. So even you see at baseline, diarrhea rates and respiratory. So respiratory diseases are also linked with hygiene because obviously they're transmitted through contact too. Then this is the 6-month behavior change outcomes, right? So the top one is a composite of these 5. I can explain how it's done, but you can basically see that here's a control, 600 out of 4,000 odd, and in intervention, nearly 3,000 out of 4,000 odd, right? And the odds, the adjusted relative risk is, these are all highly significant. The 3 stars. So then at 32 months, where we should have nothing, we still had highly significant differences between the 2 arms of the study in quite a number of the behaviors. Actually here too, but it's not, I don't know why I haven't got a star. So then we've got here the laboratory tests from the food that was cooked at 6 months only. Those are significantly different. And also then we have health outcomes at the time were secondary outcomes because we didn't think we could make a difference, such a small sample size. So we're talking about 600 in each arm, it's not big, no, 300 in each arm, it's not a big sample. And yet we managed to, unreported, and I know reported diarrhea is not ideal, but unreported diarrhea from the mother and respiratory diseases and reported admission to hospital, we managed to find significant differences at 6 months, highly significant differences at 6 months. You can see reported diarrhea is nearly 60% reduced. And here, what did I do? I can't see it on here. What did I do? Right, thank you. And the soap availability. So this is a process outcome measure, obviously. And you can see that, these are poor communities, didn't have any soap, hardly any soap before at baseline. And now they had well, such a big difference between the two arms. And here, the clinic diarrhea visit it was an independent student that did it for his master's. So he just went to the clinics of the region and collected data for children from with diarrhea from those villages. And in that period, and you see, so because we just, as I said, I didn't believe this. We go and then at 32 months, surprisingly, still with diarrhea, not with ARI, but with diarrhea and admission reported again, we have, and with soap availability in the kitchen, we still have significant differences. This is how we reduce reactivity bias, which is the observation bias I was telling you before. Again, I'm so sorry, I can go over it if people are interested. And this is the qualitative data at 32 months in Gambia, where people were saying that they clearly remembered the songs and the behaviors and passed it on to new mothers who weren't mothers at the time of the study. Villagers were very proud of being involved and their women being March champions. And they emphasized the fun aspect, that the whole community was together and involved, and that there was financial benefits to improved health. I mean, this was their language because we didn't communicate that. And issues to do with community cohesion. When I was saying earlier, they go to the clinic together, or they go to water collection together. The committees in the village that weren't meeting were meeting more often, and so on. They emphasize issues to do with cultural embeddedness of the intervention, the joyful aspect, the branding, this MCHRI, we're part of something, raising the mother's status, as I mentioned earlier, that they were illiterate mothers, and this raised their status, staging of the behavior change, community family involvement and support of the mothers, and really enabling some level of social norm change as you can detect, the best you can detect with these methods. And fathers were saying this is done through focus groups, 16 focus groups of mothers, fathers, grandmothers, and community leaders. And fathers who previously would say, oh, this is women's work, it has nothing to do with me, were proud that they were now helping their mothers, and they were saying, well, if it wasn't for me, she wouldn't be a March champion, So that's like very interesting. And that says more or less the same thing. I would like to thank the team in Gambia and the UK and our funders, which were not very many actually for that project. And the current Mali project, which has just had its implementation of the intervention and not yet evaluation except the qualitative work. And this, we have colleagues in Mali, in Bangladesh for the laboratory work, the UK, and funding is the Medical Research Council mainly, but also a lot of sacrifice from Malian and universities in England. Thank you very much. Visit our university in Birmingham. Thank you. Sorry, I rushed through that. I hope my...
We have this, folks need to go. I know we're over now, but if anybody in the room has any questions.
Oh, sorry if I missed this. Did you look at time washing hands? Because I know I'm supposed to be teaching my kids like sing happy birthday twice. And so I thought it might be neat if they picked like a native song to.
Yeah. That's a very good idea. No, at the time we didn't. Not in Gambia, and also not in Mali, not really. But there is a lot of messages because of COVID, certainly in Mali now. It's all they have a lot of public messaging about hand washing. So again, I said knowledge is not their problem usually. There is another practice we picked up with, which I don't have time to address, but it totally goes against all of this. And so we found that in Gambia, we managed unknowingly to affect that behavior, and that is probably more significant. So I'll just mention it quickly because most people don't know about this, even people who lived in Africa, non-Africans. So there is this tradition, and we've now done work with Save the Children and WaterAid across 22 countries in Africa with the experts from their organization. And they say it exists, but there is no programs for it. And that's communal hand washing before eating. So that basically means that you have a bowl of water, like a dishwashing bowl of water, and starting from the eldest to the youngest, everybody goes like that without soap, and then you go and eat from a nice big bowl of rice and things all together. So, depending on how hygienic my last toilet visit was, you can all enjoy the benefits of that. And we've done a study and others, 1 or 2 studies, not many studies on this practice, that actually you do get transmission from people who didn't have any hand swab pathogens before the practice to after. And of course, if your child is the last because it's the youngest and most vulnerable, then it's quite a significant practice. But we found in Gambia that unknowingly in the qualitative study, they were saying, oh, and we don't do that dirty practice of putting our hands in warm water. And so very interesting. But you see, our formative research didn't pick that one up. Now, this is what I was saying about accompanying people and the need for knowledge. So if they don't know what is being hygienic and what isn't, something they've been doing for centuries, they're not going to tell you is bad, because for them, that's right. They are washing their hands. So it's very interesting because that wasn't reported back. Yes.
Oh, sorry. Hi. So thank you so much for your presentation. It was really amazing, and congratulations on like all those results. And then also that shows how much we can do with so little resources in low and middle income countries. And then what really I'm a feminist researcher, and so what really drew me was your last focus group with fathers and them tending to take
more responsibility.
Not more responsibility, but almost taking credit also for women. And so I was wondering why you didn't include them in the beginning, but only towards the end. And I would really love to see results of how it would change if more men were included, and change ideal mom to ideal parent, because
so it
ideal
is
mom.
Actually, no, we did include them at the beginning. I'm just talking about at the beginning, they were saying that this is not my domain. I don't want to be involved, right? But when the MCHRI project or my champion project took part, they felt, but actually, I want to be there because this is a good thing. So it's a kind of a self-choice, you can't impose something on people that they don't want. But if you see the logo here, can you see the logo here? We have a guy at the back, right? Whereas in Gambia, we didn't. So the idea is that this is a family thing, that you do it all together as a family. And in fact, we do encourage men and community leaders to come to these meetings and to support, but it's very explicit that they should come and support the mothers, and that the mother can't do it on their own. Sorry, mother can't do it on her own.
Just to add on, because you were saying, I don't know what community needs, and I think that's where I think the fathers are very important.
They are, absolutely. Thank you.
I just wanted to elaborate on that idea. There's so much pressure on women to be so many different things, and so I think
Except, the one thing is quite important to remember is that in health promotion and behavior change, you do need to be specific. If it's everybody's job, it's nobody's job, right? And at the moment, everything's everybody's job. And the other problem with the women in these settings is that they don't have a status. So actually giving the family a status still doesn't help that poor woman. So they really like being the male champion. So there is a difference between saying you must do this, you must do that, and saying, hey, you're someone very special for doing that. And I think psychologically, they're not the same thing. And at the end of the day, the truth is the mothers do deal with the children. And if you don't pick up the woman from where she's at the moment, you're not, but you're absolutely right. You need to involve everyone else. And as I said, we tried as well. I don't know how well we achieved the Gambia one, Mali one, but Gambia one happened organically. It's very important comments. So thank you very much. I fully agree. Any other thoughts?
We have a couple more.
Thank you.
I'm Shazine. I think we had emailed earlier.
Oh, yes. Thank you.
So
Nice
I
to
work
meet you.
with newcomer populations that
Right.
have come in their migration journey to Canada and now America. And I am struck by how we forget that we can use approaches in global health locally. And I would love to hear your thoughts on how we can use formative research design and the same kind of approaches in local global health.
Thank you. I mean, I honestly think this issue of cultural, celebrating cultural diversity is such an important reality that we choose to ignore. You know, whoever we are, actually we're more beautiful as a community for the diversity we've got. And so, you know, and communities, okay, may be oppressed because they've come to new land, but they all love to hear about their own culture. In fact, people who migrate seem to be more attached to their original culture than the culture, you know, people they left behind who now moved on, you know, like they don't really, you know, they want to do other things. So, you know, going back, if you're particularly working with a community that has an ethnic background or a particular kind of cultural background, I would say it's an absolute must, that it would be just so much more effective to go back to their, you know, and we were just talking about this earlier, that creative arts, but particularly performing arts, you know, performing arts, sorry, not performing, yes, performing arts. So it could be songs, poems, it could be drama, it could be anything. It's really quite, you know, it's soul stirring really. And I think, you know, people don't forget a tune, do they? People remember a tune they've learned as a child, whereas they might forget what was in the lecture or the classroom or whatever, right, that they were taught. So I would say we don't use drama enough. We've just done a realist systematic review of the literature on drama and maternal-child health. And there is very little work on it, actually. There's a lot on HIV and sexual health, because it's a difficult area to cover, you know, other ways. But actually, you can use dramatic arts, performing arts, creative arts in all kinds of, I would say, behavior change and reaching people to not just give information, but to facilitate deeper thought and deeper sort of behavior change. And it may be a bit hard work if we're not familiar with those cultures, but people will do it for us if you ask them. Thank you. Thank you very much. Thank you. No problem. Thank you. Thank you very much for listening. Thanks for coming. Thank you. Thank you for the opportunity. Thank you very much. Thank you so much. Thank you. Thank you. Same thing, yeah.